Well, good evening, everyone. Welcome to our VCSQI Winter 2021 quarterly meeting. Thanks all for being with us here tonight. Happy holidays to you all. Thanks for spending some time with us this evening and sharing your holiday season with us. We have an action-packed agenda tonight. Quick couple of reminders though with regards to Zoom. You guys, I think, know how to do this by now, but please feel free to interact with us via the chat feature. We'll have a Q&A feature at the end of the meeting where you guys can unmute yourselves. If you're having any IT issues, Sherry's number is here, or you can, again, contact us on the chat. Again, this is all on the participants window. I think you guys are probably pretty familiar with Zoom now. And yeah, please remember that we'll have a Q&A session at the very end of the meeting here. We also offer CME credits to all attendees. We'll record your attendance automatically. So as long as you're signed into the Zoom, we will be able to follow up with you afterwards. The only piece there is they will contact you for a survey. You'll have to go to this website here on the VCU Health CME website. And that's where you will fill out the survey, and then you can claim your continuing education credits. And we'll follow up with that information after the meeting as well. This is our agenda tonight. We have an action-packed deep dive into acute kidney injury. A lot of great presenters. We have a multidisciplinary approach, some cardiologists, some surgeons, some perfusionists, as well as a first look at our VCSQI AKI recommendations from our panel. But first up, I'll introduce our VCSQI chairman, Dr. Robert Shor from Virginia Heart. Dr. Shor will give us an update from the VCSQI board. Dr. Shor.
Thank you very much, and I wanted to welcome everyone. Thank you for being on the quarterly meeting, and again, wish everyone happy holidays. May the best of 2021 be the worst of 2022. We have a wonderful meeting and focused on AKI, but first let me give everyone a brief summary of the board meeting. We have several evergreen items that we talked about. We are making progress on. One is the STEMI database with VHAC, and more will follow at upcoming meetings. Obviously AKI, which we're going to have a deeper dive today. The shock work group continues to have follow-up, has a meeting coming up in the near future with further updates from that. Angiogram reviews, we are reviewing those through MACPAC, and so far 3 centers have had cath reviews. So those other institutions that are interested, please let us know. We are trying to sequentially add more and more. We have the Evergreen Healthcare Disparities Work Group that we'll be working on in the coming year, and of course TVT. One other item that we did discuss is update from the nomination committee for the next vice chair, establishing that the role is 5 years, 3 years as chair, 1 as vice chair, and 1 as immediate past chair, and help define some of the roles and responsibilities, and we'll have more information as this process evolves. This is coming up, I'm completing my 2nd, about to start my 3rd year, so it's time to have a vice chair. We did a financial update, and we are doing well, fortunately. We have reviewed some of the actual investments that we've made, and we'll be reviewing that to make sure that we're fiscally sound and appropriate. That is a brief summary. And with that, I want to turn it back over to Eddie. I did want to just underline that the mission is to transform cardiovascular care to improve patient experience and value. And so thank you all. Eddie?
Thank you so much, Dr. Shor. So without further ado, I will introduce our first presenter of the evening, Dr. Greg Dehmer from Carilion Roanoke. He is their medical director of the Carilion Cardiovascular Institute and also professor of medicine at Virginia Tech Carilion School of Medicine. Dr. Dehmer will give us an overview of the AKI definitions within the Ncdr and STS databases, as well as a look at the current VCSQI data. Dr. Dehmer.
Thank you, Eddie. Like Eddie said, in the next 10 minutes or so, I'm going to go over what are the official NCDR and STS definitions, and then take a look at the recent data that we've accumulated in VCSQI. Next. So the NCDR definition, a lot of people ask, where did this definition come from? Well, it comes from a consensus statement that was formulated by the 6 groups that you see listed there, starting with the Acute Dialysis Quality Initiative and down through the KDIGO group listed on the bottom. The references are provided on the bottom of the slide, and their consensus definition reads as follows: an abrupt, within 48 hours, reduction in kidney function, currently defined as an absolute increase in serum creatinine of greater than or equal to 0.3 milligrams per deciliter, a percentage increase in serum creatinine of greater than or equal to 50% or 1.5-fold higher than the baseline, or a reduction in urine output, documented oliguria of less than 0.5 mils per kilogram per hour for more than 6 hours. Next. A lot of people ask, well, where can I find these definitions? I'm sure all the data managers listening know exactly where, but for the physicians, may not be as familiar with where you can find a lot of information in the NCDR. I think everybody over on the left-hand side is used to going to the dashboard for the data, but if you scroll on down to something in resources called documents, and then scroll on down, when that menu opens, you get to the Executive Summary Measures and Metrics Companion Guide, which you can download. And for the Cath PCI registry, this contains all of the key definitions that you need to know for this particular registry. Next. If you open up that document, what you will see, this is metric number 39. It's PCI in-hospital risk adjusted acute kidney injury for all patients. It comes from that publication by Tom Tsai, which is listed there. It's several years old now, but it's still the definition that's in use. The model specifications are exactly as listed and exactly as I read to you on the earlier slide, with the increase in serum creatinine greater than or equal to 0.3 milligrams per deciliter. The numbers that you see in parentheses off to the side there, the 6050 and the 8510, are the actual field codes within the database that you can actually find the information you need to get out the changes in creatinine. Next. Likewise, where does this STS definition comes from? Well, it comes from a publication of what's called the RIFLE criteria. That's an acronym that stands for risk, injury, failure, loss of kidney function, and end-stage renal disease, or RIFLE. And you can see over on the left-hand side of that picture, kidney failure is defined as an increase in creatinine of 3 times the baseline, or an absolute value greater than or equal to 4 milligrams per deciliter, and the acute rise must be more than 0.5 milligram per deciliter. Next. Where do you find this? Well, you find this off the STS website, and if you look there, I'm sure many of you are familiar going there. It's version 4.2, and if you open that up and scroll down to a document called Additional Resources or Data Specifications, that will open up the Adult Cardiac Surgery Data Definition document. It can be found at the website, which is listed on the bottom of the slide. Next. And if you dive all the way down into that, you will find the definition there, and it's as we indicated, indicate whether the patient had acute renal failure or worsening renal function resulting in one or both of the following: an increase in serum creatinine level 3 times greater than baseline, or a serum creatinine greater than or equal to 4 milligrams per deciliter, and the acute rise must be at least 0.5 milligrams per deciliter, or a new requirement for dialysis post-op. Next. So here are both of these definitions on the same slide. You can see that they're similar. Next. But they're really kind of apples and oranges. They both involve an increase in creatinine. They both involve some increase above the baseline, and they both have in common a new requirement for dialysis. But clearly the limits for what defines renal or acute kidney injury is different in these. Next. So what does that look like now in the observed rates within our VCSQI database? And these are data beginning in the first quarter of 2018 on through the second quarter of 2021, or some 42 months of data. So the NCDR definition, which is 21,138 patients in the database here, and you can see it quarter by quarter. And on average, it's about 7.3% with a median of 7.2, so it's fairly evenly distributed from quarter to quarter with very little variation from quarter to quarter. On the bottom is the STS data from VCSQI accumulated in a little over 10,000 patients. You can see a little more variability, but on average, it's 2.7% of patients get AKI post-op, and the median is 2.6. Next. The incidence of new dialysis from the NCDR is about 0.5%, 0.45 to be exact, and new dialysis after isolated coronary artery bypass surgery in STS, 2.2%. Next. Now, both the STS and the NCDR have risk modeling. It's basically the equivalent of an O to E ratio. And you can see the NCDR here is in blue, and on average, it's about an O to E ratio or risk adjusted ratio of 0.81. It's a little bit higher using the STS definitions from STS, and it's 1.16. And you can see quarter by quarter the changes here, but the averages are not bad. They're 0.81 and 1.16. Next. And this is the final slide. I have to thank Eddie for putting this together. This is the what if slide. What if one applied the NCDR definition of AKI to the STS data? So this is from all VCSQI hospitals, isolated cabbage. The time frame you see there, about 10,000 patients, and the median and the average are given there. And you can see this helps to bring out the definitions and the difference in the definition that you'll see if you apply the NCDR definition to the STS data. It's about a 23-24% incidence of renal or acute kidney injury, mainly because the criteria are so much different between NCDR and STS. Next. So at this point, to move things along in a fairly efficient manner, I'm going to introduce Dr. Nicholas Teman from the University of Virginia, who's going to present a case study. Thank you.
All right, great. Well, thank you so much for the opportunity to talk to you all today. I am going to believe I'm going to be able to control this. We'll see. So I'm going to talk to you today about a patient, and I'm going to kind of try to tell a story that kind of brings all of this together. You know, I was tasked with taking this topic of AKI and making this a little bit more identifiable for all of us. All of us have taken care of patients that developed renal failure, and truly it's a very multidisciplinary process. And so I'm going to kind of bring us through a patient that kind of sets the stage for the rest of the talks, and hopefully complements the talks that are going to be following from the different perspectives of the different stakeholders and the different folks within the VCSQI. So unfortunately, this is a story that's not too uncommon. This is a 70-year-old male who came to the emergency department and noted that he was having some increasing chest pain and pressure, which he first noticed the day before. You push him on and he says, well, I've had some chest pain for a while, but it's really gotten worse over the last day. And he's got a pretty significant past medical history. He's got hypertension, he's got hyperlipidemia, he has diabetes for which he takes insulin as well as some oral agents. He has some degree of chronic kidney disease, a baseline creatinine of about 1.2, sometimes up to 1.4, an estimated GFR of about 65 milliliters per minute. And he's had a pretty significant coronary artery disease history. He's had several previous MIs and multiple episodes of PCI and stenting. He takes all the usual medications that you would expect this patient to take. So medications for his blood pressure, medications for his diabetes. He takes a statin, he takes aspirin. And like I mentioned, of note for his diabetes, he does take insulin. So the ER starts diagnostic workup. He gets some laboratory values. His creatinine is a little bit higher than his baseline. It's now 1.4. His troponin initially was 0.42. And so the cardiology service was consulted, but over the next 12 hours, his creatinine actually rose to 12.3. They got an EKG in the ER, which was not terribly concerning, but there was a presence of some ST depressions in the anterolateral leads. The cardiologist saw him, and given his rise in his troponin, given his worsening chest pain, there was significant concern, especially given his history of coronary disease. So it was arranged for him to get a left heart catheterization the next day. So he got that, which showed very significant coronary disease. His previous LAD stent now had a near occlusive in-stent restenosis. His left circumflex was completely occluded. He had significant disease throughout his right coronary artery, and then some disease in some of his diagonal branches from his LAD. Of note, a total of 50 cc's of contrast was used for the cardiac cath. He also had an echo performed, which surprisingly showed an EF of 25 to 30%. And this was significant because his previous echo from just 5 months prior had a normal ejection fraction, no valvular disease, and he actually had moderate to severe mitral regurgitation on this new echocardiogram. So the cardiology or the cardiac surgery service was consulted, and the tests for CABG, the CABG workup were performed. And during the process, while the cardiac surgery team was seeing the patient developed some worsening clinical picture. He had some worsening chest pain, and he actually became fairly hypotensive with concern for cardiogenic shock in the setting of his new reduced ejection fraction. So he had a balloon pump, went back to the cath lab, got a balloon pump placed, and then was transferred to the coronary care unit where he was treated with some diuretics, some vasopressors, and as you would expect, given his baseline renal insufficiency, he did have a spike in his creatinine. It actually peaked post-cath at 2.3, and then ultimately returned to about 1.5 or so. So not quite to where it was at his baseline and where he arrived in the hospital. So the nephrology service, during the time that his creatinine was elevated, the nephrology service was consulted just to kind of help with preoperative optimization and recognizing the impact of the cardiac cath on top of the cardiogenic shock that would have on his kidneys, and the need for a CABG, which would also negatively affect his renal function. So the nephrology service was consulted, and this is just a brief blurb excerpt from their consultation note, which was, a major surgery like a CABG would place this patient at moderate to high risk for requiring dialysis in the future, would defer surgery if possible until AKI is recovered to reduce renal risk from surgery. And I think, with all due respect to our nephrology colleagues, this is kind of one of these things that's kind of, easier said than done, right? I mean, this patient is in a tough spot. He has cardiogenic shock related to worsening coronary disease. He has worsening chest pain, which has gotten better with a balloon pump, but still has worsening chest pain. And to be honest, we don't often or always have the luxury of time. We know, and we'll hear more about this data and the recommendations later on this evening. We know that if you can delay CABG for longer after the initial cardiac catheterization, that we know that the risk of AKI is much lower. But we don't always have that luxury. In this patient, actually, the cardiogenic shock got him a little bit further out from the cardiac cath, because even though he's having worsening chest pain, that got better with the balloon pump. And we really needed to get his hemodynamics a little bit under better control, get his fluid status a little bit under better control before he went to the operation. So ultimately, after several days of diuresis, he had another echocardiogram, which showed an ejection fraction improved to 35%. His MR was now mild. We felt like he was in a better place, and he was taken to the operating room for a 3-vessel CABG. So Lehman-Taylor's LED, a vein graft to his PDA branch of his right coronary artery, and a vein graft to his diagonal branch of his LAD. His occluded circumflex did not have any bypassable targets. It was a difficult operation. His targets weren't that great. He had, as you can imagine, a pretty significant calcification of his vessels. It was a difficult operation, as manifested by the time that it took to do the operation. So his clamp time, cross clamp time was 112 minutes, and his bypass time was 141 minutes. Oh, I wanted to highlight this. So this is his, I'm sure is familiar with the Sds Risk Calculator, but this is an online calculator that we use routinely for our patients prior to cardiac surgery. We are able to input several data points that encompass all of the preoperative risk factors and characteristics of the patient. And based on the SCS database as a whole, gives us a predicted risk of the patient's mortality, as well as the major morbidities that you see listed here. And I want to kind of highlight that this patient's predicted risk of renal failure was 7%. And I think that all of us that do this for a living would look at this patient who has all of these risk factors, has new cardiogenic shock, has a balloon pump in place, came in with an elevated creatinine, already had a spike in their creatinine earlier in this hospital course that is now resolved. I think all of us would feel very certain that this patient's risk of renal failure is almost 100%, let alone higher than 7%. And so it just goes to show you that the metrics that we have and some of the tools that we have just aren't quite what we need them to be. Dr. Dehmer talked about the definitions and things like that, and it's just we're at the end of the day, we're taking care of individual patients, and it doesn't always fit with the kind of overarching tools that we have. The other thing I'll note is that on post-operative day number 1, this patient's NephroCheck value was 1.27. And so for those of you that aren't familiar with what that is, the NephroCheck is a urinary test that incorporates 2 different urinary biomarkers. And the idea is that these biomarkers are measures of renal stress. So the thought behind this is that prior to the creatinine rising, prior to the urine output decreasing, we would be able to measure renal stress in the urine with the form of these 2 biomarkers. And they've been shown to predict the onset of AKI within the next 12 hours. So it's kind of a snapshot of 12 hours in the future. The normal value for a NephroCheck is less than 0.3. So this patient's NephroCheck of 1.27 was actually very, very high, very significant, and certainly portended a poor prognosis in terms of avoiding dialysis or avoiding AKI. So I want to show you, so this is the patient's creatinine trend over the course of his whole hospitalization. So from admission to discharge. And so right here, you can see the point where he got the left heart cath, and then you can see the spike that came after that associated again with the contrast administration, as well as the cardiogenic shock that he was in. And then you can see that, like I said, it came back to close to his baseline or close to his admission creatinine. And then you can see right about that time that his kidneys were starting to recover and in a happy place, we assaulted him with another insult in the form of this CABG. And that's where you really see a pretty significant spike in his creatinine in the days to follow his operation. And then the rest of these spikes are related to the fact that at this point where it was escalating rapidly, he was started on CRRT and then ultimately transitioned to IHG. And so some of these spikes are associated with periods of intermittent hemodialysis and transient reductions in his creatinine. So his postoperative course, so initially he was started on diuretics pretty quickly after the operation because of the low ejection fraction and concern for volume overload. His cardiac index was good, and his balloon pump was removed fairly soon after the operation. He responded well to diuretics, had a good urine output. But ultimately, over the course of the next couple of days, kind of in the period of time where you expect mobilization of fluid and volume overload, he wasn't able to keep up from a urine output standpoint and did become volume overloaded and was started on renal replacement therapy. He was ultimately transitioned to intermittent hemodialysis after a couple of days of that. His postop, of course, was complicated by all the usual things that you would expect for this patient. So things like ICU delirium, atrial fibrillation, AKI that we've talked about, and then, probably related to the balloon pump being in for nearly a week at that point that it was removed, that he developed bacteremia and some septic shock. So a really tough clinical picture, a low ejection fraction, septic shock, AKI, and really a difficult patient to manage from an ICU standpoint. Fortunately, he ultimately recovered from those things. He was transferred out of the intensive care unit on postoperative day number 12, and ultimately was discharged to a skilled nursing facility on postoperative day number 17 with a tunneled HD catheter in place and still receiving periodic intermittent hemodialysis. Now, this patient was actually very fortunate. We know a lot about the negative impact of a renal failure. We know a lot about the negative impact of hemodialysis after a CABG. This patient actually did quite well. In 6 weeks after surgery, he was no longer requiring dialysis. He had an improvement in renal function, and his tunneled hemodialysis line was removed. And he's still alive and kicking 2.5 years now after surgery, and he's been remained free of dialysis since that time with a baseline creatinine of a little bit higher than it was before, so 1.5, 1.9. And also of note, which I think is really great for him, is that with the improved blood flow from the revascularization from his CABG and some time from the initial insult from his NSTEMI, his LV ejection fraction has now improved to 50 to 55%. So, like I said, this is a good outcome, but I would say it's a little bit of an uncharacteristic outcome. We see this all the time where a patient comes in with some degree of renal insufficiency. They have their cath, they have their heart surgery, the CABG or whatever valve operation they're getting, and they develop renal failure after the operation. They go on dialysis, and it's just kind of one complication begets another, and they don't make it out of the hospital, or they make it out of the hospital to a nursing home to never get back home. So this is a real patient. This is a case that I wanted to present to kind of set the stage to hear the perspective from the cardiologist, from the surgeons, from the perfusionists, and then introduce our recommendations. So thank you again for the time. I'm going to introduce Dr. Kerry Prewitt, who is a cardiologist at Sentara, who's going to talk about AKI from the perspective of the cardiologists.
Thank you, Nick. So I'm Kerry Prewitt. I'm an interventional cardiologist in Williamsburg, Virginia. I'm going to present on behalf of Sentara Healthcare. So let me just see. So am I able to advance the next slide?
Dr. Prewitt, you'll need to click within the Zoom window to take control of my screen.
There we go. So this is sort of the cardiology perspective. It says you have a heart murmur, and I'm starting to hear your liver and kidneys complain too. Now, obviously, we focus on the heart, but we've got to deal with a little bit more at times. So this is what happens. This is what we've been talking about tonight is kidneys in bad shape following a cardiac catheterization. So Sentara had recognized this as a problem. We had set some metrics. Our 2021 goal was 5.7% acute kidney injury and new requirement for dialysis of 0.3%. So we felt like we had some room for improvement there. So we got a team of cardiologists and administrators together to focus on looking at the kidneys. So sort of a unique thing. We've also had, as part of our clinical variation project, we want to develop service line quality initiative to reduce the risk of contrast nephropathy, acute kidney injury, and new requirement for dialysis following cath procedures. So this group got together. I'm presenting on behalf of this group. Much of this work was done before me, and I was kind of the tail end of the whole group, but several cardiologists, several administrators got together, and they took a lot of the information that was already out there. They took the best practices that were there. For those of you who are looking for best practices, you can look at Society for Cardiac Angiography and Intervention. They have two consensus statements, one from 2016, one from 2021, looking at best practices for the cath lab. You can also look at American Heart evidence-based practices for the cardiac cath lab. That's from 2021. And so I'm going to summarize what was very long statements, but basically what they said was hold nephrotoxic drugs, which include non-steroidals, ACE inhibitors, ARB inhibitors on the day of the procedure, hold metformin, calculate contrast nephropathy risk, arrive early for the procedure, and then give fluids or sodium bicarb at a fairly high rate for 3 to 12 hours prior to the procedure and for several hours after the procedure.
Oh, where am I going?
So within the cath lab, they said to calculate and review contrast nephropathy risk, use low osmolar or isoosmolar contrast, use the LVEDP to guide IV fluids following the procedure, use a radial approach, keep contrast low, less than 100 cc's, use a contrast volume less than 3 times the GFR, that's generally considered safe, and use practical approaches to limit contrast dose. Those include automated injectors such as the assist or divert, try to avoid an LV gram, use 5 French catheters, use an echo to assess wall motion and LV function, try to avoid multivessel PCI, and try to avoid ad hoc PCI if they already have known renal insufficiency. What they said do not use Mucomist anymore. That's kind of gone away. And they said there's no clear benefit or recommendation for sodium bicarb ACE inhibitor to prevent problems, targeted renal therapy, fendolipam, dopamine, forced diuresis, or the type of contrast. There's been some discussion about whether Visipake was superior. They didn't find much evidence to support that. So their bottom line was more hydration, less contrast. So that's what Sentara took, in addition to several other articles, and came up with this contrast in the NCDR definition, which we've already talked about. They've already identified high-risk populations. I think the case that we just discussed highlighted all of those problems. There we go. Whoops. So let me see if can I go back, Eddie? There you go. Thank you. So we divided it up into what to do pre-procedure, what to do inter-procedure, and what to do post-procedure. So pre-procedure,
This came today.
we want to avoid contrast loads within 72 hours. So for instance, like a CT scan, we have the frequent situation of patient in the ER, chest pain, short of breath, gets a CT scan, and then they decide they've got heart failure and they want a cath the next day. So you're getting 2 pretty big loads within 24 hours sometimes. So we need to pause a little bit. And then prior to the angiography, we should figure out what's the ideal and acceptable contrast volume. So 3 times GFR, but less than that's considered safe. We want to try to figure out the ideal and acceptable contrast volumes to be included in the pre-procedure timeout. So we do that as part of our timeout at our hospital. So ideal is less than 2 times GFR, acceptable 3 times GFR, and maximum should be 5 times GFR. So that's something that the techs will call out and say, hey, look, you've kind of reached your contrast limit, proceed at your own risk. You want to give good hydration. So we have our secretaries tell people to drink 16 ounces of water the night before, 16 ounces the morning of the procedure to make sure they're pretty well hydrated. When they come in, they get 3 cc's per kilogram per hour prior to the procedure, and after an hour decrease to 1.5 cc's per kilogram. And everybody gets prehydration unless it's contraindication due to renal failure that you've already known about, or acute or decompensated heart failure. Within the procedure, as part of our timeout before we get started, we review serum creatinine levels and GFR. We check what fluid they're getting. We make sure what's our contrast limits for the procedure, acceptable and maximum. At our hospital, we use an assist device. In this slide, it says, consider the use of that. I think most hospitals, you either use it or you don't. You wouldn't necessarily pull it out just for higher risk people. So within the procedure timeout, say you've done a catheterization, you're getting ready to intervene. We do a timeout in the middle to say how much contrast have we used, kind of review what their creatinine is, how much difficulty do you think you're going to have, how much contrast do you think you're going to use, can you get this done safely, review the fluid rate and how much fluid has been given. And at the end of the procedure, we measure EDP, and then you can take from the Poseidon study, which had recommendations based on what your EDP was to guide you for how much fluid to get. So if your EDP is less than 18, it's 3 cc's per kilogram per hour. The standard rate's 1.5 cc's per kilogram per hour. And that's for 4 hours. And then we ask the nurses to do handoff to either the recovery room or the ICU where they're going, to tell them what the creatinine is, what's the contrast volume given, what's the fluid volume given, and what we want the fluids to be following that. So post-procedure, we've already kind of figured it out by our EDP of how much fluids they get, either the 1.5 or the 3. If doctors haven't measured the EDP, we're suggesting that they just use 1.5 kilogram per hour for 4 hours. Following the procedure, for high-risk people, we'll check a creatinine. We kind of leave that to physician discretion, is what they think are high risk based on baseline characteristics, how much contrast they use. So they may check that in a couple of days as an outpatient. You want to reassess when you want to resume diuretics and then hold the nephrotoxic meds for 48 hours. So this is all those slides I just told you put into one sheet. This is what got passed out to each hospital to do all of that. You're going to see on there, let's see, which version do we have? Yeah, so this is a newer version. One of the first versions had calculate risk of contrast nephropathy. There are apps. SCAI has an app that you can download on your phone. You can calculate that as well as mortality. There's also other apps. There's other fairly easy ways to do risk calculation. But we found that I wasn't consistently doing it. Other doctors weren't doing it. And so we didn't really think it changed management very much. So that's in the advanced category if you want to proceed with that. But otherwise, we tried to make it a little simpler to have more people adopt it. So we've done away with the risk calculator. So here's the final result. Hopefully happy kidneys, happy heart. So I'd be glad to answer any questions when we finish up. And so next I want to introduce Kevin Lobdell, who's retired from the Army. I'm now working for patient care. He's going to give us the cardiac surgery perspective on kidney injury.
Thanks, Kerry. Just to check to make sure, Eddie, you can hear me?
Yes, sir. And you just need to click the screen and now you can control the slides.
Terrific. Briefly, for those that aren't familiar, Kevin Lobdell with Atrium Health out of Charlotte and the Sanger Heart and Vascular Institute. I depict our new Heart and Vascular Institute, which is great to be in, real bonus in this COVID environment. Whoop, that went backwards. Eddie, can you get me back to these slides?
Yeah, hang on, I will get us back ahead here.
There we go. And then for those that aren't familiar, we have the medical school from Wake Forest, which is now part of Atrium Health, to be started in Charlotte. I think it's 2024, as well as an innovation corridor. You're hearing a lot about that nationally, and we think there's a great opportunity there. So it's pretty exciting. Eddie, for some reason, it keeps flickering to the previous presentation when I click.
Dr. Lobdell, try your arrows. Those tend to be better. They tend to work better in this forum.
Yep, and all it does is make a noise and doesn't advance it. Okay, well, hopefully we'll get through this. Eddie was kind enough to create this schematic for what we're really trying to accomplish with the Perfect Care Improvement Network and the collaborative that we have with you. And so you'll see data warehouse where we have the novel data from the Perfect Care, along with the work that you guys have done so brilliantly over the years with matching up clinical STS data, for example, in cardiac surgery, and then the financial data. And we think that the real opportunity here is bigger groups of motivated individuals that are expert in a variety of areas, as well as the novel data, the larger volume of data, so that we ultimately shorten our learning cycles. And we do that through both the investigations that we have, as well as sharing the insight that we gain. Here's a brief overview, and you've seen the format of this slide. We're coming right up at the end of the grant period at the end of December. We're now closing in on 700 patients. And interestingly, as we continue the updates, the great results with post-operative length of stay being about a day less than benchmark, 30-day readmissions right in the area of 4.5% or 50% or better than the benchmarks. It continues, so it's a persistent finding. And then I may have to have you control these slides, because when I click, it keeps bouncing around. There we go. There you go. And the thing that I thought was really interesting, we just got the Watson Health 2022 report, and both Carolinas Medical Center and Pineville, which have been the first two programs that we've implemented Perfect Care, were both awarded top 50 cardiovascular centers. As everybody here probably knows, that's a combination of cardiology and cardiac surgery, which is great. But all the results that we have, whether it's STS or these external perspectives, continue to align, and that is the work we're doing seems to be great. So we really think there's, as I mentioned earlier, a great opportunity to take these techniques, these technologies that we have, implement them, use them, that such that we can learn together. So I'm really grateful for the opportunity to share. Next step, next slide. The thing we're going to start in the first quarter here of 2022 is what we've talked about in the quadruple aim of better, cheaper, improved patient experience, relates to that fourth domain of improved clinician experience. We're working with the renal labs, and we'll do some work to try to help optimize performance of our individual clinicians and teams. So that's a really exciting way to take a combination of very technical biometrics on sleep and their activities, as well as recovery, and then teamwork and individual coaching to try to, again, complete this quadruple aim and see if we can't continue to learn and improve here on the outcomes. Next slide. This is a mock-up of what that looks like, just briefly, from Arena Labs. Next slide. And you can click it twice. What you'll see that I've learned was I was sleeping about an hour a day less than what or maybe half an hour less than the SEALs. Next demonstrates that on the right. And working with the coach who spent 22 years in the SEAL team, really gave me the license to say it's okay to sleep a little bit more. Interestingly, the other sort of insight that I had there was, I think I was always thinking in terms of efficiency and efficacy, and he helped me think a lot about energy management. And that's been really something that I've been able to incorporate into my thoughts on a daily basis, and I think optimize my own personal performance. Next slide. this is what that looked like over a 6-month period. There was a fair amount of red recovery. Next slide. And you can see that with that coaching, at least in this 1 month, and this slide's a couple months old now, but I was able to go from what you saw was probably pretty evenly divided, but certainly a lot of red to very little red, with both the insight of the data as well as some coaching. So again, this fourth domain of clinician optimal performance and how it can impact our patient care and results, I think is a tremendous opportunity. Next slide. So you heard a little bit about the AKI schema earlier from Greg, and certainly reinforced by Nick and Kerry. So I'm not going to go over that again, but it has evolved over the last 20 years pretty significantly. Next slide. You know, going back to, in this case, 2005, there was this early indication that small changes in creatinine increase the odds of death. And it, as you guys have pointed out in some of your studies, increases hospital length of stay and incremental costs. So it's really a significant burden. Next slide. Here was a look by colleagues next advanced that it's from 2013, and they estimated in cardiovascular and thoracic surgery the rate of AKI between 9 and 49%. And as you've heard, it depends on whether it's AKIN or rifle, whatever scheme one uses, and whether you're talking about, say, coronaries plus valve, thoracic. But the point being, it's a prominent problem. And advance that, please. Most recently in JTCVS 2021, there was a Canadian study that was fairly large, about 10,000 patients. You can click one more time. And what we found in this was 25% incidence of AKI, and again, increase of the length of stay and sort of that incremental impact based on how severe the AKI is. So again, what we see is it's a common problem, and it's got a dose response type of effect. Next slide. As I alluded to, you studied this brilliantly and published on the incremental cost, and back in that publication in Annals of Thoracic Surgery, I think it was 2008, demonstrated that there was about a $49,000 incremental cost to acute renal failure in adjusted dollars for that year. Next. Here was the length of stay. I think if you click on that, demonstrated that there was a 23.7 day increase for isolated renal failure. Next. And then click that one more time. This is a combination of Maryland, Virginia, so I'm sure some that may be on the call participated in this, but our friend Bob Higgins and the others demonstrated that by just impacting AKI after cardiac surgery 10% could save potentially $100 million a year. So what we're saying is it's a common problem, has significant impact, including financial impact. So it's great to see this group focusing on this. Next slide. Recently in press, the failure to rescue update that we published, and this was from the J. Maxwell Chamberlain paper presented last year by Paul Kurlansky, we demonstrate that there was an 8.9% in the STS adult cardiac population for those that had isolated renal failure. So again, it's common, it's costly, and it's a significant impact, whether it's sort of the administrative side of length of stay and readmissions, or on the mortality side that's so important to the clinicians and obviously the patients and their family. Next. Click that one more time. This relates to what Nick touched on, but Jeremiah Brown et al. With the work or collaboration with QMTF, Quality Metric Task Force, and the STS, looked at stage 1 and 2 and 3 AKI and correlated with readmission and mortality risk. And as you can see there in the highlighted green, there's marked dose response, as I mentioned earlier, to the stages where you see, for instance, in AKI stage 2 and 3, a 98% increase in readmission risk and 348% increase in 5-year mortality. Next. Next. This is some of the work I mentioned that Nick was pointing out, the biomarkers. This is some of the work we've done in collaboration with Jeremiah Brown and Dartmouth and Northern New England and QMTF. Just highlights the utility of biomarkers. And you've probably seen, if you're a student of this, a series of publications, which I'm glad to share with the team. Again, looking at readmission and mortality risk associated with cardiac surgery. Next. So I'm sure some of you have heard me talk a little bit about our history of AKI and the quality improvement program. We broke this down in a phase of care, pre-op, intra-op, ICU. Next slide. We've published on the quality improvement program, both of those publications, JTCVS and I think it was American Heart Journal 2008, but we'll really focus, you can advance that here on goal-directed therapy and the impact on AKI. Next slide. What we did was educate our team about the risk, evaluate our processes through those phases of care that I mentioned, and then we worked to mitigate modifiable risk, much like you heard earlier, and that's score the risk, delay after radio contrast. At that time, a real focus on our hemodilution processes, meticulous hemostasis, glycemic control, goal-directed therapy, and I highlight what our goals were, which was index at 2.2, SVO2 of 60, and a blood pressure 100. We would modify that a little bit if somebody, for instance, had severe systolic hypertension pre-op. And we also thought it was really important because we'd see oliguria, as I'm sure everybody does, the opportunity to intervene appropriately when oliguria does arise. Next slide. So for those that aren't familiar, goal-directed therapy was popularized by Shoemaker, setting physiologic goals, employing various therapeutic strategies with the aim of mitigating risk of untoward outcomes. And you can think of those goals being macro and micro, the macro being things like blood pressure, cardiac index, SpO2, as I alluded to, in urine output, but micro can be things like oxygen debt, lactate levels, and biomarkers, which we touched on. Next. Goal-directed therapy has been popular and published on in cardiac surgery, particularly in the ICU. I won't belabor the point. The point is others have looked at this and demonstrated some differences, so it's worth reviewing that. And again, I'm pleased to share articles because I have a large reference library if that's valuable to anybody. Next. Specifically, I'm sure like many of you in our ICU, our ACPs have guided the goal-directed therapy, and after educating them and engaging them in this process, we use the goal sheets, which we've talked about in previous occasions with Virginia, and reinforcing that we were typically using albumin for volume expansion, most common inotropes, dopamine and milrinone, and then vasopressors of neosynephrine and vasopressin. And then the methods, thinking blood pressure, cardiac index, SpO2, and urinary output to guide that. Next. We even took the time to catalog what we found that we were doing. And again, I'm sure like most of you, what we demonstrated in the first hour after surgery is the patients were getting volume, they were warming up. If anything, the inotropic needs were going up, not down. And when I say that, it's important, it's not that they go up markedly, but oftentimes somebody would see a good cardiac index historically and immediately start weaning inotropes. And I think that that's probably not consistent with the typical trajectory of a patient. And then, as you can imagine, we give more volume early and then that tapers off over time. So next. We coined this phrase, the kidneys aren't smart, but they know when they're not happy, and it really refers to oliguria. Some of the nephrologists pushed back and said, actually, the kidneys are very smart, but it's important to know that when patients oliguric after cardiac surgery, that's really unusual because they typically would have polyuria in association with the cardiopulmonary bypass run. And now, depending on the use of things like off-pump coronary, that's less of an issue. But the point being, in the vast majority of the patients we see, if they're oliguric after surgery, something's amiss and it needs to be looked into and addressed. You can click that. This is just an overview of a study by Ngoran and others at the University of Michigan. They did a nice heat map. You can click it one more time, correlating oliguria with the risk of death and complications. And we wrote a nice invited commentary reinforcing our similar views on this. If you haven't seen it, it's a good article that they put together. Next. I know I've shared this before, but there are probably people wondering, like, great, but tell us your results. We had quite a journey as we worked on this. We started back in 2003 and had a renal failure rate that was 3 times the rate of renal failure, approximately 3 times higher than the national average. And it was real impetus for us to do better. And with this assiduous attention and approach that we've taken, by 2014, we had 0. And if you look at the 16 months, the 30 months that followed through 2016, we had 3 of about our 500 coronaries with about 0.6%. So at that point, that was about 1/4 of the national average. So it was somewhere in the area of, 15-fold improvement. And I did include the results at that time, just so people realize it wasn't a sleight of hand, that overall we were doing well. Next slide. And that just, and you can advance, it's just demonstrating the impact financially based on some of the work that you do if you just annualize those savings. Next. So Prev AKI we'll touch on, for those that don't know, a more recent publication with Care Bundle for AKI. They wanted to look at high-risk cardiac surgery patients. So they use goal-directed therapy, avoiding nephrotoxic drugs, preventing hyperglycemia, and use the renal biomarkers to detect those high-risk patients. Next slide. This is what that looked like, and I won't bore you with the details, but the point is they randomized it and they looked at these patients using that same nephrocheck technique that Nick alluded to earlier, with 0.3 being the definition of high risk. If I remember, Nick mentioned 1.2 or something like that. So this patient was even higher risk. Primary endpoint was the rate of AKI by the KDIGO criteria within the first 72 hours, and then a variety of secondary endpoints that you see there. Next slide. This is what the results looked like, and AKI was significantly reduced in the intervention compared to the control group. There were no significant effects on secondary outcomes. Next slide. So the conclusion was that implementation of the KDIGO guidelines compared to standard care reduced the frequency and severity of AKI after cardiac surgery in high-risk patients. Like many of these things, they call for further study, but it was something that's consistent with our experience and beliefs and some of the others that are incorporating biomarkers at this point. Next slide. I mentioned goal-directed perfusion just for sake of completion. I know we've talked on various work groups and maybe even in the previous plenary about the upcoming STS, AMSEC, SCA recommendations. And at least with our working paper, what we're going to talk about there is goal-directed perfusion, specifically for patients undergoing cardiac surgery with bypass, avoiding a nadir oxygen delivery index of less than 270 mLs per minute per meter squared to reduce the risk of AKI. So I won't go into the details of that. I know we'll talk about perfusion later, but I wanted to give a little insight into that phase and specifically where we are with that. Next. With that, I'll pause. Thank you. And as always, thank to the family and team that support all the great work we do. So next is Bridget Kelley, perfusion, as I mentioned, from Winchester Medical Center, and I'll hand it over to Bridget. Again, thank you.
Hi, everybody. I'm Bridget Kelley. I've been a perfusionist for 21 years. And I've worked my entire career in West Virginia and Virginia. I'm currently the clinical coordinator of perfusion at Winchester Medical Center, and I'm employed by Perfusion.com Incorporated. I have a few specific things that I'd like to talk about. There's a long list of recommendations and interventions currently in discussion on this topic, and I have 4 very specific things under my control while I have the patient on bypass. I'd like to focus on these while I have the opportunity to speak to you today, and we can discuss some pharmacological interventions, specifically mannitol administration, temperature control and strict temperature limits on bypass, control of fluid balance and the use of ultrafiltration. And I want to spend a few minutes talking about oxygen delivery. Like Dr. Lobdell just mentioned, oxygen delivery on bypass has turned out to be pretty important in the AKI literature. I'm trying to advance the slide. I think I got it. Eddie, do you think you can help me with that?
I'm sorry about that, Bridget. Give me just 1 second.
Okay.
PowerPoint is acting up here a little bit, I think. All right, try it now.
Okay. There we go. Okay, so let's start with mannitol. Historically, mannitol has been a component in CPB priming solution at most centers. And recently, a lot of centers have started to remove mannitol from their CPB prime as evidence shows there's no benefit. It's no longer considered necessary or beneficial to give it to every patient. Mannitol is still shown to be beneficial at promoting diuresis and achieving lower fluid balances during CPB. And this is helpful to maximize hemoglobin levels and contribute to overall tissue perfusion. Additionally, mannitol is a popular component in some cardioplegia solutions, such as Delnido and KBC solution, where its free radical scavenging and osmotic capabilities are more useful to the myocardial tissue. So we can use mannitol in more targeted ways rather than empirically dosing all patients undergoing cardiopulmonary bypass. See if it lets me switch the slide. Eddie, can you take me to the next slide, please? It's not letting me do it. There we go. Okay, next I want to talk about temperature limits. We've known for quite some time now that overwarming patients is detrimental. It's previously been shown to correlate with poor neurologic outcomes. That's widely accepted in our field of work. We follow safe temperature gradients and limit arterial blood temperatures to prevent overwarming. Recently, overwarming has been focused on again in the literature and has shown to increase the incidence of AKI. The Newland article from 2016 shows that an arterial perfusate, and by that I mean the temperature of the blood exiting the oxygenator heat exchanger. When this temperature is greater than 37.0 degrees, it is an independent predictor of AKI. In that same study, arterial perfusate temperatures of 36.0 and 36.5 were measured, and they were not associated with AKI. So as perfusionists, we have to show care in rewarming our patients and use the technology available to us to do that. The current heater coolers on the market are considered accurate. They're considered accurate on the readout to 0.2 degrees. So we can target our perfusate temperatures very specifically. We have temperature monitoring ports available on all makes and models of oxygenators. And the temperature monitoring can be set to an audible alarm on most heart-lung machines. So we can set ourselves up for success by utilizing the safety features within our equipment to prevent excessive perfusate temperatures on bypass. Next slide, please. Okay, ultrafiltration. Ultrafiltration has been discussed in relation to renal function for as long as I can remember. This is a topic that I found to be very surgeon and center specific in my years as a perfusionist. Some centers are very big on hemofiltration, some are not. Some surgeons want to use it often, some surgeons want to use it never. While ultrafiltration can be very useful to achieve lower fluid balances and to maximize hemoglobin levels, are we overusing it and contributing to AKI? That is likely so. A retrospective study from the Journal of Cardiothoracic and Vascular Anesthesia states that ultrafiltration volumes greater than 32 milliliters per kilogram increase the risk for postoperative AKI. Now, a large meta-analysis study by Candle that just came out online ahead of print, that study says that ultrafiltration in cardiac surgery is not associated with increased AKI incidence, and it can be safely used even in baseline chronic injury patients. So this topic remains controversial, and my takeaway as a perfusionist is this: ultrafiltration should not be overused. Sometimes it's necessary. For example, when we use cardioplegia solutions with large crystalloid volumes, such as Delnido, that volume has to be removed to preserve the patient's hematocrit. If a patient cannot tolerate RAP before going on bypass, we like to use ultrafiltration to remove some of the prime volume, or to zero balance ultrafiltrate for potassium removal if it's necessary. In Winchester, we concentrate our pump volume that's left in the circuit post-bypass with a hemoconcentrator, and then we return it to the patient so that we preserve the plasma component rather than putting all of that residual volume from the pump into the cell saver. So lots of different uses for ultrafiltration. They're not all bad, but we shouldn't overuse it. Careful and judicious use of ultrafiltration is appropriate and useful, and it can be tailored to the patient's specific needs, and the decisions should remain a team consensus. Next slide, please. So this brings me to the last and most important topic I want to talk to you about today, and that is this equation for O2 delivered. So this is something that all perfusionists learned and memorized for boards, and it's something that you pull out from time to time when you have a situation that you're unsure of. If you're perfusing the patient well enough or not, you can do this calculation. But many people are not calculating this regularly on bypass for every case. And now that it's come to the forefront of the AKI discussion, I think it will be much more commonly utilized. Next slide, please. So The beginning of this discussion that I knew of started with the Newland article, not the Newland article on temperature. It's the same group, but a different article. And it was published in JECT in 2017, and it was presented at the STS meeting that year. And I have a friend who was lucky enough to attend that meeting, and she came home and handed me that article and said, you know how we've been talking about blood management for the last 10 years in perfusion? This is the topic for the next 10 years. And she was absolutely right. It's the hot topic, and I think we will be speaking about it for the next several years. We've gotten really good at preserving hemoglobin and keeping patients relatively dry. We've had success with minimized bypass circuits, smaller cannula size, but sometimes the cost of this is the pump flow. We've reduced our pump flows sometimes to enable us to make headway with blood conservation. We've perfected those techniques with the goal of minimizing transfusion, and we've been successful at that. But now we can move on to the related topic of AKI and how those two things intersect. It's time to take a close look at acute kidney injury as it relates to cardiac surgery in general. In our attempts to maximize hemoglobin and our abilities to reduce AKI, we have to look at the O2 delivered equation. So we can see that the two main factors in that calculation are blood flow and hemoglobin. So if the hemoglobin goes down, the blood flow needs to go up. If the blood flow goes down, we need to rely on more hemoglobin to carry the oxygen. So we can't achieve an acceptable DO2 without optimizing those two things. So it's good that we have made such progress in our practice of maintaining adequate hemoglobin levels, because we've at least got that piece of the puzzle pretty well preserved. The consensus on recommended DO2 indexes on bypass is 270 mils per minute per meter squared. And that's almost impossible to achieve at hemoglobin in the low 7s or at flows below a 2.0 index. Just if you calculate this out, if you have a patient with a hemoglobin in the mid to upper 8s, you need about a 2.3 to 2.4 index to achieve a DO2 of about 280. The lower the hemoglobin, the higher index is needed to maintain the adequate DO2. So the Ranucci article back in 2005, that told us that low hemoglobin levels are associated with AKI, but it was possible for this damage to be offset by increased pump flow. Again, the two key data points in the DO2 equation are pump flow and, sorry, I had some background noise there. Assuming that the PO2 is always adequate on bypass, we've got our pump flow and our hemoglobin that we can control to maximize our DO2. So Newland in 2017 makes that connection of total oxygen delivery as it's related to AKI. And numerous other studies are beginning to come out and be published, and it's understanding this relationship between DO2 and AKI. Can you switch the slides, please? Next. So I looked back at a few charts recently and was able to identify a few patients that I thought would be at high risk for AKI during their cardiac surgery procedure. And I calculated the DO2 during their pump runs. And in these instances, we were able to achieve adequate hemoglobin levels and flows, giving us successful O2 delivery on bypass. And even though these patients should have been in a high-risk group for AKI, neither one of them had an AKI. And I think it was our careful management of them during the course of their treatment that contributed to that outcome. Next slide, please. So here's what we as perfusionists are doing to achieve our DO2 goals. We're using our blood conservation techniques that we're all well versed in by now to preserve our patients' hemoglobin levels. We know that we may need to adjust our transfusion triggers from time to time for patients at high risk for AKI. Pump flow is equally important. We look at our cannula choices and sizing to maximize potential pump flow. So we want to give ourselves room for extra flow should we need it. We can plan ahead to maximize that pump flow if we know we will be borderline on the hemoglobin levels. We can also use our other tools that are widely accepted in the cardiac operating room as adjunct decision makers. We pay close attention to our cerebral oximetry, and we can use that to fine tune our blood gas management. I like to look at venous blood gas in addition to my venous saturation while on bypass. And I like to make sure that the CO2 difference isn't widening out and that the venous PO2 is adequate. If our DO2 is adequate and all of those other targets are in acceptable range, we should do well by our patient. If they're not, we should be directed towards the correct line of troubleshooting when deciding which interventions to make. And we can use our charting technology, back to technology, to ensure that adequate DO2 is achieved. So I'm lucky to have a charting program called OnCloud, and it has the calculation for DO2 built into it. So the DO2 is calculated for me every time I enter blood gas values with a number that turns red if it drops below 270 and it stays green if it's above 270. So I have a nice visual indicator on my screen. If you don't have this technology built into your charting program, there are some other ways that you can achieve a running DO2 so you don't have to do that math while you're on bypass. Epic, if you chart in Epic, Epic can do this for you, and some of the inline blood gas monitoring, such as the CDI 550, can calculate a DO2 for you while on bypass. So in conclusion, I want to say that the data on AKI is pretty much in line with the data on neurologic outcomes and blood conservation. When you incorporate blood pressure management, that's a big focus that we've been looking at our center recently. And all of these things lead us in the same direction. So I think we as a group of in the cardiac surgery arena will be talking about AKI for the next several years. And it's great to be part of this focused committee and see how these efforts overlap with our previous work for overall patient outcomes. And that brings me to my last slide. Does anybody have any perfusion specific questions?
Okay, actually, we can hold the questions towards the end for our Q&A section. Section. But up next, we are going to give you a debut of the recommendations of the VCSQI AKI recommendations that were prepared by our extraordinary VCSQI AKI work group. So I'll hand it over to Chris and Mike Brown, who are the co-champions of this work group.
Chris, are you going to go ahead and start?
Okay, here she is. She's off mute. Chris, try to say something. Okay, we're having a bit of technical difficulties. So Mike, should we start down at the surgical area?
Sure, that'd be great.
Okay. And I'm gonna also give you control.
Yeah, Well, if you'd like, I'll be honest with you. With my technological computer skills, I think maybe you could just do the scrolling for me.
All right, sounds good.
Sure. So, before we get started, one thing I would say, Chris is going to, hopefully we get the technology issues sorted out, but Chris is really going to go over, kind of recap the Sentara protocol, which is what we have adopted as part of our cardiology component of the AKI reduction recommendations. Before I talk a little bit about the cardiac surgery recommendations, I do want to convey that this probably represents about 60% of the elements that we reviewed before adopting these recommendations. And for those programs who have existing AKI protocols, you may see that some things may not be inclusive on this document draft. And I just want to say that, there was a thoughtful process for us in going through all of the elements that we had originally identified this past January when we started out. But we used, the same I guess, algorithm that STS has used in the past for the consensus statements, looking at class of recommendation and level of evidence. And we did that to the best of our knowledge. There are a few things that are on our draft that don't have those elements to them, but they're very common sense and very much part of the contribution of physicians that we interviewed and talked with, including nephrologists and cardiologists and CT surgeons, many of which are on this call tonight. And so with that in mind, I think that this gives us a good framework to start with, and we're really open to suggestions from other programs who have existing protocols that have been successful. And this is the first iteration. And so we're very much open to adopting those to these recommendations and suggestions for care. It's by no means an absolute protocol. So getting started here, our preoperative, we've broken cardiac surgery component into 3 sections: the preoperative component, the intraoperative component, and obviously the postoperative care component. So ideally, and I think everybody does this just because of the STS registry, we all obtain a serum creatinine level prior to going to the operating room. And then for those patients with high-risk AKI or pre-existing AKI and a contrast exposure prior to surgery, consider continuing IV hydration, and also consider getting a nephrology consult. Discontinuing nephrotoxic medications, our ACE and ARBs. We agreed that 48 hours prior to surgery would be ideal just because of the timing of consults and the timing of when patients go to the OR, be it AM versus afternoon procedures, hold ARNI medications. That's something that was new to our protocol within the last month or two because of some issues that other programs have recognized peri and postoperatively. Consider discontinuing metformin 24 hours prior to surgery, and then obviously avoidance of NSAIDs. And I think many programs out there are doing these things as we speak. For the past few years at least, and that's a class 1A recommendation. Renal consult for post-cath AKI, pre-op AKI with the GFR less than 45. Consider delaying surgery for 48 to 72 hours. And once the GFR returns to the nadir or improves, that's a class 2C recommendation. Consider atrionatriuretic peptide, ANP, pre-surgery. This recommendation comes from the STS draft, as well as recommending intra-aortic balloon pumping for patients with low EF. That's a class 2A level BR recommendation. Do not use dopamine for renal protection preoperatively. That was an STS SCI recommendation. for no benefit, class 3, level A. And then consider phenoldiprem infusion preoperatively, and that was a class 2B level BR recommendation from the STS draft. And then getting into the intraoperative component, avoidance of hyperglycemia, maintain a blood sugar less than 180. That's coming from the KDIGO bundle class 2A level BR recommendation. As Bridget had mentioned, avoid mannitol in the CPB prime, class 2 no benefit, class 3 no benefit. But as she mentioned, you know, a lot of people use that in their cardioplegia. We use it for circ arrest cases, for a variety of other cases. And so when there is a direct indication, rather than just using it for all patients, it clearly is acceptable. Avoid hyperthermia on bypass, as Bridget detailed. That was a class 1 level BR recommendation. Goal-directed oxygen delivery on bypass, class 1 level BR recommendation coming from the STS draft. And then consider identifying a blood pressure baseline pre-induction, and then establish and maintain a mean pressure throughout the procedure. And the rationale behind that is that many programs have been using blood pressure targets during cardiopulmonary bypass. And I think the feeling of our committee is that if you are implementing the DO2I recommendations and you're maintaining at that 270 milliliter per minute per meter square target, and then you are then titrating your blood pressure to that mean, it would probably be beneficial to patients. And there are programs that we've talked to who have used mean targets, and they've improved AKI in their program. And so I think a lot of this depends on perfusion, and perfusion has been perfusion is regional. And you know, I trained at the Cleveland Clinic, worked in Pittsburgh for 5 years before I came here. Bridget will tell you she's trained in a different area, and many perfusionists come from what are considered to be high flow regions versus low flow regions, believe it or not. And so I think that if perfusion, at least within VCSQI, kind of comes together and accepting DO2I with the understanding that you achieve that target and then you shoot for your goal mean pressure, I think we will see even more improvement in AKI. Consider minimally invasive extracorporeal circulation techniques. We've been doing that for a long time, as Bridget had mentioned. Consider phenoldiprem infusion during cardiopulmonary bypass. These recommendations, again, are from the STS draft. There's a no benefit for dopamine infusion for renal protection during bypass. And then again, for those patients with low EF, recommend intra-aortic balloon pumping and consider using the intra-aortic balloon pump counterpulsation during cardiopulmonary bypass. That was a class 2A level BR recommendation. As Bridget had mentioned in detail, consider limiting ultrafiltration with following exceptions. You know, for those programs that are using higher volume cardioplegia like Del Nido, those patients that come in acute cardiogenic shock. But I think that there's also room for the single pass ultrafiltration, blood conservation techniques after termination of bypass. But in general, there is some literature out there suggesting that just globally using zero bounce ultrafiltration techniques may be harmful and may contribute to AKI. And then cerebral oximetry, which I believe was in the KDIGO recommendations. That's a class 1 level BR. And then the last section, keep going, is the postoperative section. And so again, having a thoughtful process about doing serum BUN and creatinine postoperatively within a defined order set so that it's consistent. consult nephrology for that, or reconsult nephrology for pre-existing AKI, or consult them for new post-op AKI with a GFR less than 45 and or anuria. Avoid PO or IV diuretics until post-operative day 2. That was kind of a consensus among our group with physicians and clinicians input without any class recommendation. However, I think there was some intimation of that in the STS draft. Do not use dopamine infusion for renal protection. That was a no benefit. Class 3 level A recommendation. And then again, and I'm not going to list all these things out because Dr. Lobdell eloquently presented that to us. But again, the recommendation for the KDIGO bundle, as well as the evidence bundle of care, which really is looking at, avoidance of those nephrotoxic meds, hyperglycemia, close urine monitoring, hemodynamic monitoring, goal-directed therapy, tying all those things together to improve and reduce AKI. Is Chris available
I'm
on there
here.
yet?
Can you guys hear me?
Absolutely. I'm glad you're able.
Thank you.
Glad you're able to get
I
on.
just want to go on record. We tested this at the beginning. I was on during the during our other meeting for the board, and I was perfectly heard. So I apologize sincerely. I also apologize. I do have some residual laryngitis that I've been working through. So I have the privilege of going over and just really reviewing the pre-catheterization recommendations for intra-cath and post-cath. And this is a lot what you're going to see is what we heard from Carilion and Sentara. And I can tell you that as the group, we were actually struggling at first to figure out, based on all the recommendations that we read across literature, where should we start? Where should we go? And out of the blue, there comes Sentara and Carilion to save us from ourselves and give us a pretty good area of recommendations. So here we go. Okay, this is your pre-catheterization recommendations. Obtain a baseline serum creatinine. I thought it was very interesting that they actually said if there's no known kidney disease, you could go within 30 days. I'm not sure I know of a lot of cardiologists that would go 30 days before they got a creatinine. So normally, if there's known kidney disease, I say like around 7 days. If the patient has unstable renal function or maybe class 3 or 4, within 24 to 48 hours of known contrast exposure. Holding the nephrotoxic medications, you're seeing here what you've heard before: NSAIDs, metformin, aminoglycosides, antivirals, amphotericin B. Now, it was interesting here because in some of the literature, there is not both ACE and ARBs being held. There was actually a pretty neat article that I was reading that actually showed that ACE may itself be a protection against renals. So this is kind of a little bit in the literature different, but in most areas, I believe ACE and ARBs are being held as well as your ARNIs. And the diuretics, calculating the Marin score is actually optional. I think they spoke about that when they represented Sentara Carilion. It does, though, look at a difference of like whether a patient had an IBP, congestive heart failure, what class, age, and hypotension. Anything greater than 11 was considered kind of risky. So there are other scales out there on the market, but probably the Marin score was the most publicized. Avoid contrast loads within 72 hours and prior to your angiography. Identify your ideal, acceptable, and maximum contrast volume. And this was actually broken out for you that ideal would be 2 times the eGFR, acceptable 3 times, and maximum 5 times the eGFR. For hydration, if the BMI is greater than 35, we're using ideal weight. And for all patients except those with end-stage renal disease or decompensated HF, they were looking at giving oral fluids the night before surgery and that morning, running normal saline at 3 milliliters per kilogram per hour times 1 hour. And then after the hour, the standard rate of 1.5 for a fluid max of 500 milliliters. The next one is intra-procedure recommendation. During your timeout, discuss what the serum creatinine level is, what is the risk score if it was calculated, and where are the ideal and acceptable contrast limits. For contrast, they are trying to minimize it. I think you're right. Everybody now is trying to do that. They have injectors, other ways that they are trying to really pay attention to contrast volume. But if your GFR is less than 30, actually could consider contrast saving devices. And again, just about everybody is doing that. Stage your procedures as necessary. If you run the cath and you feel that you can do safely the angioplasty at another date, that gives the patient a little breather in between the contrast volumes. For hydration, your fluid should be continued during the procedure at 1.5 milligrams per kilogram per hour. And looking at the Poseidon trial, if you know the LV-EDP, consider using LV-EDP guided hydration therapy. During the procedure, there should be communication between the primary operator and the circulators approaching the ideal contrast limit, let them know, and the same thing for approaching the acceptable contrast volume limit. Next slide is your post-procedure recommendation. And a risk reduction would be, again, possibly recalculating your risk score, and definitely communication. The primary operator should be informed of what was the serum creatinine level, recalculate the score if possible, and give them the total contrast volume given. We have an interesting procedure at our hospital that we look at radiation dosing, and at certain levels, we call that out to the operator. I'm wondering if doing the same thing for contrast volume may be a good idea. For hydration, your standard hydration therapy is 1.5 milligrams per kilogram per hour times 2 hours, plus 32 cc's of water, or 1.5 milligrams per kilogram per hour for 4 hours. Again, if you know the LV-EDP, consider that guided hydration therapy post-procedure. For the serum creatinine, if the patient was high risk, they recommend getting the serum creatinine within 48 to 72 hours. As you know, most of these patients are now going home first day or the next day. If you have a very, very high suspicion that this patient is at high risk, they actually may bring them back in for just an outpatient lab. The intervention cardiologist who performed the procedure should be notified in order to provide further management from that creatinine level. For medications, reassess the resumption of the diuretics, and the following should be held at least 24 hours pre-procedure and 48 hours after. Your NSAIDs, metformin, aminoglycosides, your antivirals, amphotericin B, and again, looking at your ACE ARBs in this category, as well as your ARNIs. And I appreciate very much the opportunity to speak. And I know now, I think they're going to the chat room to look at for our panel and answer questions. Thank you.
Thank you so much, Chris. Thank you so much, Mike. We just want to take a moment to recognize all of the hard work that the members of our VCSQI AKI work group has put into this. They have met tirelessly over the Zoom, doing a lot of research to prepare this for us. We just want to give a special thanks to Mike Brown, Chris Sytsma, and I'm sorry, Chris, I always butcher your name. Please, I'm sorry. Dr.
right.
Nick Teman, thank you. Dr. Nick Teman and of course, Dr. Kerry Prewitt are our co-champions of this work group. We also want to give a special recognition to Dr. Cauchi and members of the Carilion Clinic who have laid the foundation for cardiology protocols, and as well as the tireless work of the Sentara healthcare system who have helped to enhance the cardiology aspects of the recommendations. So going into the first question that we have for our panel, please forgive me. The first question is actually for Dr. Prewitt. Are you still with us? Yes, I see you here.
Yeah, I'm still here.
Great. Thank you again for an amazing presentation. The first question comes to us from Dr. Robert Shor. I think we know who that guy is. Can you share with us the impact of AKI from the protocol?
I don't quite understand the question.
Dr. Shor?
Was Bob still there?
Yeah.
Yeah, I'm here. So how has implementing the protocol impacted your AKI rates?
Yeah, so now I understand what you mean now. So we've piloted it at 2 hospitals because one of my partners championed it at Virginia Beach. I've championed it in Williamsburg because it required required our office staff, the prep nurses, the cath lab, the doctors. So we didn't want to roll it out until we'd gotten some of the bugs worked out. So it turns out the first week we did this, we had 2 people come in and heart failure. So we realized we were doing a little too much fluid. So that was one problem. The second problem we recognized was we're not really doing the risk scores. So the one that you mentioned, the Marin score, that's actually calculated afterwards. So it's a little, I mean, you can calculate it up front, but you don't really know some of the variables till after you finish the procedure. So that one's not very practical. It didn't really change your management. So we found that people weren't doing it. So we just, we're at my hospital, we stopped doing it. So we do the other things. So because it's only 2 hospitals, we haven't really looked system-wide to say, has this changed the needle at all? Is that what you're asking? Did it change things?
Yeah, as we are moving forward with protocols, sharing the results of the protocols, tweaking the protocols to enhance. Ultimately, our goal is to reduce the AKI, improve care. So I just didn't know if you had any preliminary information.
We don't have any preliminary data yet.
Yeah, very helpful. Thank you very much for all your work.
Of course, glad to do it.
Okay, there's no more questions in the chat, but if anyone has any questions, please chime in. Dr. Spear, I see you have a question. Nice haircut, by the way.
They cut all the gray out. Let me thank the panel for this this great overview. And I'm struck as you were talking, this would make a stellar monograph. So all too often, at least I'm guilty of looking at everything in a silo. And as a surgeon, I have full confidence in those behind me, our perfusionist, and at the head of the bed while we're just operating. But I think that the time has come that, just like we've seen in structural heart, as well as our shock and so many other things, the great overlap with all of our groups, and how no longer can we be the individual, but what happens in the cath lab and affects us in the operating room, that affects the critical care, that then affects, as Nick Teman said on that great presentation that hit all these points, a stellar outcome that should have just as easily gone the other way. And so it's really motivated me, at least, to go back and hopefully share. We can have, this has been recorded, and go back and listen to the different components of it, because I really do need to pay more attention to what's going on in the cath lab and see, are we adhering to what we heard? And is that something that all of our cardiologists can come to grips with? And in so doing, all of our surgeons can use better skills and better sort of astute recognition of what this means and how it's impacted, as Kevin Lobdell showed so well. Because heretofore, creatinine of 1.5, 1.7, so what? That's normal, really. Well, no, it's not. You know, with huge implications and profound repercussions from both the cost and clinical outcomes. So this is really, you know, plus I have to compliment our folks in putting this together, which, as we saw with shock and this, having these focused reviews really allows us to get into the weeds in ways that we weren't able to do because of time constraints. That has motivated us, I think, all of us, to look at things differently and appreciate what we're doing more collaboratively. So thank you again for this, and I hope Share, this will be available on our website.
It absolutely will.
Good.
I will send out an email tomorrow to, well, may take a minute for the recording to generate, but I will definitely send out an email announcement of when it's available.
Thank you.
No problem. Okay, Dr. Shor, you had another question?
I don't know if Dr. Dehmer is still here, but one question that comes up, that I've heard from some of the my interventional colleagues, is 0.3 rise at the appropriate rise? STS uses 0.5 plus some other things, and Dr. Dehmer pointed out quite nicely what the impact of NCDR data on the STS and how it might change the percentages, but what is the data to suggest that 0.3 is the right number? So I don't know if he's still on, or if someone else on the work group wants to comment.
Dr. Dehmer had to step away for a personal obligation. Mike or Judy, I know there was a lot of discussion about that in the work group. Would you, either of you like to answer, or Chris?
Well, I think that this is Mike, Mary Washington. I think, the consensus we got from him is that it was based on the recommendations of those work groups. And that's where it was adopted from. He kind of expounded on that on one of our calls early on in developing this protocol. And I think I'll say this because he's not on the call now, but I think he was disappointed that, for cardiac surgery, it was 3 times the baseline creatinine. And I think he was a little bit stunned that we got away with that high of a number compared to how the cardiology component is much more punitive. So that's really all I can add to that. But I think where they came up with that was that consensus from those quality initiatives.
I just think, this is Chris, we still have to remember that this is a projection of like on a timeline. That rifle criteria, you're looking at 2 different elements. You're looking at injury, and the kidney said, hey guys, I'm a little scared here. And then it actually has failure. So I think they're just 2 different mechanisms, and that's what we need to remember.
Thank you so much.
Great.
Do we have any other questions for our panelists, our work group? Go ahead.
The other thing I'd like to say is what I had mentioned when Chris and I were talking about our protocol. I know that there are some programs out there, both in Maryland and in Virginia, that have intraoperative protocols where they've incorporated, what they have determined to be best practices in AKI reduction. And I think our group would like to get that. We're soliciting for that feedback, that information, because I do think that this isn't the final iteration of these recommendations. I think that it is, this to me, and having gone to these meetings for over 20 years, is probably the first, I guess, I don't want to use the word protocol, but the first draft of recommendations that we have put together that's really a continuum of care that starts before the patient even gets to the cath lab. And for the cardiology members of VCSQI, I think it's important to realize that this isn't just self-serving to cardiac surgery. It's these people that go get a cath, get a PCI and go home, or whether they get a cath, they need to go off to surgery, or whether they don't have any intervention whatsoever and they have normal coronaries. The opportunity for us to just improve the continuum of care as it relates to AKI, I think, is critical, and it's probably something that's unique to this initiative. I don't know that in reviewing the literature out there has been any effort that has drawn cardiac surgery and cardiology together to create this type of opportunity.
Yeah, I just wanted to add that I think this is fabulous. We look forward to the final output for the protocols. I would like to see personally a cathing protocol, a bypass perfusion protocol, and a bridging protocol. A protocol when you go from cath to surgical intervention to bridge the 2. That would be extraordinarily helpful as we move forward. What do you see as next steps with the AKI work group in advancing this effort?
Mike, you want to take that? I know we talked about this.
I'll let you do that. I don't know if Dr. Teman's on here either, but why don't you go ahead, Chris?
Yeah,
I've
Dr.
talked too
Teman is
much.
on the line.
Yeah.
Pardon me?
Dr. Teman is here.
Oh, do you want him to answer that question, Mike?
Let's give
I'll
them a
take
chance to
crack.
talk. Yeah, go ahead.
I don't have the answer, but I mean, I'll take a crack at it. I mean, I think that the first step is crafting these guidelines, and then the second, I mean, in my mind, then starting to look at the kind of implementation science aspect of things, and actually tracking what centers are doing, and kind of getting more granular in terms of the outcomes that we're measuring, and really trying to impact significant change in the rates of AKI in our patients. So that's kind of my thoughts, but I haven't cleared that with anyone else. That's just my thoughts off the top of my head.
I would agree, and Dr. Shor, I mean, I hope our group didn't miss the mark here, but I think that this protocol actually is intended to go from one level to the next, to bridge us from the cath to the cardiac surgery OR. And so I think we would actually love to get some feedback from you as to what those elements that maybe we've missed that you would be wanting to see in this draft that would address that.
I think the work that you all have done is phenomenal. It's a huge endeavor, and I really look forward to the output. I think fixing kind of the preload issue with cath-related AKI as you go to surgery will help fix that issue as well. And so I think you guys are on target and spot on. I think this has been fabulous.
And we also know that all the organizations have not been represented. So we want to share the protocol, and we talked with Sherry and Eddie about sending out a letter that they have done, like when they did with the atrial fib operation doing mitral replacement repair, kind of sending out an informational letter to let people know about the protocol. And then in a month, we talked about 1 quarter wise, sending out a survey to see if there had been a change in practice, how people are using the recommendations.
I think that's perfect. And as these protocols get implemented, sharing what have been the obstacles to adequate implementation. I found the discussion for Sentara was really interesting.
Yeah, I mean, yeah, go ahead, Chris.
I was just saying, for me, I spent a lot of my time in cardiac surgery and then cardiology, maybe the last 5 or 6 years. This information that crosses these two areas is so key. And I think it's going to make cardiac surgery look a little more like Dr. Sear talked about. I think it's going to make more an awareness of the creatinines at a very lower level than I think we used to look at before.
One of the things that we talked about at our perfusion VCSQI perfusion committee call is, it made me think, going back to our blood transfusion studies that we did, gosh, I don't know, what's that, about 9 years ago, Dr. Spear? I'm trying to remember, where we adopted the STS transfusion triggers. And I can't remember how many programs opted into that, but what I'd love to see is whether we can add some fields to the ARMIS and to the STS database, looking at some of the perfusion goal-directed therapies, because it's clearly obvious that that was a focus in the STS draft. And so maybe there's some other fields that we might be able to consider. I know there's a lot of our database managers on this call, and we're all very sensitive to creating more work for them, but it might give us the ability to be able to track which programs are using DO2I monitoring and be able to compare those AKI outcomes and see if there is a true link. We've got such a huge repository of data, and look at our hemoglobin, which we're tracking pretty closely. Look at DO2I. We can look at max temperature, and then we can add some of these other elements to the registry and look to see if we're making any traction using this protocol. I don't know what your thoughts are, Dr. Spear, Dr. Teman, any of the surgeons that are on the call, Dr. Treble.
I think that the database managers would need to weigh into this, because collecting that data is critical to answer your question, but we've got so many things that we're trying to track on these different databases that it becomes quite onerous to start adding more data to this. The caveat to that, though, is that I think within the perfusion realm, there's a lot of information that could be captured from your records during the procedures that is, while part of the record, isn't necessarily something that we've focused on and learning from. At least I haven't, but it's a wealth of data there that answers some of the things that were alluded to with that really nice presentation from our perfusionist, which I learned a lot about. And I'm going to start asking a lot more questions during the course of the procedure. So Monique, I think you raised some interesting points, but it's a matter of there's just so much data we can collect. How do we prioritize it? And then conversely, how can we use other sources to tease out what it is we want to know, if I'm interpreting your question correctly?
Yeah, I agree. Because I am one of those people that enters that data. So any less data points, I would agree with it. And it might be that we might be able to go back in retrospectively, knowing which programs that are using that technology, and just tease out the data by center, comparing to those that don't. But it would at least give us maybe a snapshot. But I would agree with you. And I think Bridget, I don't know if she's still on this call, but there are other folks from different centers that are using DO2I, and I think they all agreed that it is challenged perfusionists out there to meet that expectation. It's not easy on all cases to achieve a DO2I of 270 milliliters per meter squared, per minute per meter squared. It's not. And so we've had, very similar to Bridget, we've had probably a half a dozen patients very similar to her case presentation where we have avoided AKI. And I'm virtually certain that had we not been using DO2I, we probably would have had a renal failure. So for the surgeons out there, I think, your perfusionists are really relying on the physicians, to support those efforts, because it does, for us, it's required us to, on many patients, use a larger arterial cannula and just have different considerations for cardiopulmonary bypass.
Bridget, is that value on the perfusion report that gets generated?
The cannula size is on my record. It is.
Okay, and what about the DO2?
The DO2, it does not print out on my record. It gives me a running number during my pump run, but it is not recorded on the record.
Okay.
But you can go back for any data point and calculate it.
Right. I just thought maybe it was on that report that's generated.
Yeah.
Okay.
Max temperature, all of those other things should be able to see. You should be able to see on that record.
Okay.
Any other questions or concerns? Or any other questions, any other feedback you have about the fabulous presentations this evening?
Hi, this is Beth Hart from Mary, Washington, and I do have just one kind of a follow-up question for Bridget. When they were talking about the lab that was not necessarily documented, but is one of those that we needed to follow, is there a place where she would consider documenting that in her record? And is that something that we could also do maybe within Epic, so that we are able to track that for our patients to be able to work on our renal challenge?
Yeah, sure. We could incorporate that pretty easily as a data column in the record. It wouldn't be hard to do at all.
And Beth, just to answer your question, it is on our record. So we're actually working with Epic, the same folks that work with Tom Akers at Carilion, to create a goal-directed perfusion scorecard so that we can track all of our AKI efforts from our perfusion team. So we're focused on temperature control. We've removed the mannitol and the DO2I. So we're doing those things currently, and as well as mean blood pressure control.
You see the temperatures, Mike, but I don't always see your DO2. I'll go back and look at that. Maybe I just never paid any mind to it.
Thank you so much. Well, we're just a minute beyond our allotted time. Again, just to thank everyone, please stay tuned for an updated email from us. We will send probably a couple of separate ones. We'll send out the recording for you as soon as it's made available on our website, as well as key features and highlights that will be included in our upcoming newsletter. Before we depart, Dr. Shor, I want to pass it back to you for any closing remarks.
Just in summary, I thought this was fabulous, very timely, extremely important in the cardiovascular health of our patients, surgical and non-surgical. So this was tremendous, and thank you for the effort. Again, I want to wish everybody happy holidays. If you're traveling, safe travels, stay healthy, stay safe. We'll get the information out, and if you have feedback you want to share regarding the meetings and our approach on focus topics, please let us know as well. This is your organization. So thank you very much. Alan, anyone else?
Happy holidays and thanks to everyone.
Bye all.
Thanks all. Take care.
Good night.